You, Charles, please stay here. Together with Hannu, I'm wondering, mi chiedo se qualcuno dei nostri commentatori o qualcuno dei nostri...
I wonder whether some of our commentators have questions to ask with regard to the things that have been said.
Una delle cose che mi veniva in mente da chiedere, da chiedervi o da...
One thing that I would like to ask is, what are the suggestions that we have already followed vis-à-vis the experience which has been accumulated? There are a few things that shouldn't be done, okay? So, what are the 5 practices that have a high probability of non-appropriateness in building up our quality systems? Which are the 5 practices? Well, I would like to leave this hall with an idea of the things we do which are useless, harmful, but we continue doing that because we've always done that. So could you mention 5 practices that are non-appropriate, that are inappropriate, but we continue to do them? There are many of you who still have a lot of experience on quality systems or so-called quality systems. If you wish, you can also think about it for some time. Up to 1 o'clock we have time. And we can just keep our thoughts moving for the time being. What are the things that can help us? Can help us spare poplar trees that are grown in Friuli to produce paper. So how can we possibly spare that to help patients?
Un'altra, io ringrazio i colleghi perché i pensieri... C'è una... Oh! Abbiamo una grande cardiologa.
We have a great cardiologist here with us who would like to make a comment, apparently. You have 30 seconds. I'm a cardiologist working at the Aviano Oncology Center. Some of you have said, quite rightly, that we must start from small things that constitute a problem. And everybody says they constitute a problem. Unfortunately, in my own practice, there are things that, to me, are a problem. Maybe they are a problem also for someone else, but it is difficult to convince all the people involved that they constitute a problem. I'll give you a practical example. I'm a cardiologist, and I work as a consultant at the Oncology Center. My response should give clear information on what should be done, whereas there are some colleagues of ours that give us just generic information, too general information, and they don't think it is a problem. If you ring them up and you say, I didn't understand what you mean by these instructions, they think that the others are stupid and misinterpreted the information, and that they were clear, crystal clear and transparent in their responses. Thank you. Thank you for the opportunity that was given me. I would like to thank you not only on my own personal behalf, but also on behalf of the body that I represent. Very interesting things have been said on the organization, on the roles of individual professionals, on how we should work in the field of quality. We as nurses have a very clear idea of the notion of quality, but we find it difficult sometimes to bring it home to the management. We hope that people will work from the point of view of quality, not only in terms of quality of processes, but above all, the quality of life for the patients, and therefore also the quality in terms of the assessment of the outcome of the care we provide. So how can we possibly interact with the political systems? We are getting across a period of far-sweeping change in our region with this new law. How can we as professionals have our voice heard? How can we underscore which and what are the real needs that our citizens have? So, 2 questions.
Answers, questions, replies.
I'm not sure I have a very good answer to that last question, particularly about nursing. It's something that's always surprised me, that given that nurses outnumber doctors in most countries by 5 to 1, and they are the ones who actually spend more time with patients than doctors do, that their voice is not heard more. In some countries, particularly going back to the less fortunate countries, the training of nurses and the role of nurses is far less well developed than it is in Western Europe. And I think this does make a big difference. And even in my short clinical career, I saw a major shift away from some tasks being done by junior doctors are now done by nurses, and they're generally done much better, like putting up intravenously and so forth. So there's been quite a shift of what they call transfer of function in North America to nurses. So I think at the clinical level and at the policy level, the governments would do well to listen to nurses. Certainly in the UK, I think it's fair to say that the Royal College of Nursing had been pushing things like standards and organizational development long before the medical Royal Colleges did. So, and I would say this in many countries, if you have a competent cadre of nurses, use them first. The trouble is we have to persuade the doctors to listen to them. Team working is a key element in quality improvement, and in many countries it's a major obstacle.
Hannu?
Well, I'd just like to continue on that the better the level of education of nurses, the more they will be heard. If I just take 2 examples from my own experience, when I was the Minister of Health of Kosovo, the level of training of the nurses was extremely low, and nobody would listen to them, even if they had something very useful to say. Whereas in Finland, where you have university level nursing education, well, the nurse's voice is being heard. So that, I think, is a key to improving that. You asked about the 5 practices to be dropped. Well, I'm not a clinician, and I don't dare to go into that area. But I would like to repeat in a way what Charles was saying, that don't emphasize the negative, emphasize the positive. And I think that, for instance, this meeting, the audience here, the welcoming addresses, both yesterday and today, in my mind, show that you have a good dialogue with your politicians who seem to understand what is needed and so on. So build on that. And also you have a very, it seems to me, very active, vibrant professional association for quality assurance, so that is an asset, and build on that rather than try to identify what's wrong.
It was the theory of good apples. Yes.
Sorry, I escaped the first question about what things not to do. There are quite a few things which have been well demonstrated to have very little clinical value. Surgery for glue ear. Overprescribing of antibiotics is very common. I've found several countries where prescribing antibiotics is actually a means of generating out-of-pocket cash. It's actually encouraged by the state in China, where half of the money for the drug goes to the hospital and the other half goes to the doctor. which is why they use cafazolin, because it's the most expensive, and you give it intravenously, because that's the most expensive way of giving it. Preoperative chest x-rays we found in the United Kingdom, it was routine. Everybody going for surgery would have a preoperative chest x-ray, regardless of whether they needed it or whether they had one done last week. Thrombolysis that's too late, cardiologists, in some countries it's given 3 days after the onset of the pain, which is probably pretty useless, but it still costs a lot of money. So there are lots of things which we have fairly good evidence are worth not doing.